Our neonate patient is a patient that has from the time of delivery to the first 24 hours. And during this time, there's quite a lot of things that can go wrong with our pediatric or neonate. So this is a specialty type care. However, just to go over, normally what we're trying to do here is just maintain our airway, breathing, and circulation as a basic EMS provider. Again, the occiput or the head is much larger than the torso and body, which causes the head to then be flexed forward. When we see our pediatric patient, a lot of times the head is much larger, and then we have a smaller oral opening, which we also have a large floppy tongue in there. These can all be problematic in causing the airway to be obstructed anatomically, to say. And our smallest area here is the cricoid ring. And so that small objects in there can cause airway obstruction. So we really want to make sure that this airway is open by using our head tilt chin lift, and then again by using a padding to pad underneath the shoulder blades to maintain that airway to be open. A lot of times the mouth is full of secretions, and so we're going to end up suctioning, and in this case we may use something called a bulb syringe or a meconium aspirator. Prior to that, the airway, we reestablish our breathing, and this we would use a smaller bag valve mask to ventilate, only to see the chest rise and fall. Any extra air that we put down can go down through the esophagus or the food tube into the gastric contents and then cause the displacement and cause the child to vomit. It'll also cause the raising gastric distension, pushing up on the bladder, limiting the amount of volume that we can ventilate the child with. And again, this causes a lot of problems with the secretions in the airway. Circulation, we're going to check. This would be up here in the brachial artery inside the fold of the arm. And we're going to need to count this out. Sometimes it may also help if we go ahead and listen to the apical pulse over the heart, and we're going to tap this out as we watch our clock and get our heart rate this way. So apical or palpated pulse, as we feel in the brachial artery, we'll tap this out as we watch the second hand go around the minute. All right. Now there's other devices that we can place on them. We can put on the pulse oximetry and the monitor and such. But in the neonate, in particular, we want to put the pulse oximetry, and this one we would put a type of band-aid or a cloth-based tape type oximeter probe, and we put this on the right side. Right? Just remember it's always on the right, so that we take the preductal blood circulation there. That would show us the highest amount of oxygenation at that time. If we need to start and get intravenous access again, we're going to probably use smaller IV needles. In this case, there may be opportunity for some advanced provider or ALS provider to use the umbilical. We would then also think about using the Easy IO or the Gem Shady device in order to place this into the bone in the proxotibial plate so that we can administer medications and fluids. Again, when we're doing a resuscitation on pediatric patients, we'd use a length-based tape. This would be placed in the head and then measured down towards the feet so we can get the color size. From this, we can identify the medications that we need, airways, and IV fluids and the like. We may also, again, set up this and attach this to an IV bag. So we would go ahead and spike this into the IV bag. The drips that would come down, and we would administer only so much volume that we would like to use for our pediatric patient. Keep in mind that our caregivers are probably the best historians. If they know anything about the pediatric patient, they've had the opportunity to learn about this from the obstetrician and pediatricians prior to delivery of the patient, from all the sonograms and the prenatal screening.